a patient with PV bleeding, and that patient may or may not be pregnant, and that patient may be first, second or third trimester if they're pregnant, and they may or may not be shocked. So we see a lot of patients with PV bleeding, so they're probably a large proportion of the O&G emergencies that we see. Number two is the preeclamptic type patient, or the patient with pregnancy-induced hypertension. Again, depending on what sort of setup you have and where you work, you may or may not see a lot of these patients. Some of them will go straight to the obstetric service. I must admit, I think these are fairly infrequent in the emergency department, but when you do see them, they're usually very dramatic because they come in seizing, and some of them might even be immediately postpartum. I'm actually not going to talk about this group of patients today. I'm going to talk about all the other three, but I have loaded up some resources regarding this into the Dropbox folder. Group number three are the postpartum hemorrhage patients. Again, we don't frequently see this, but I think if you work out in rural areas, you probably see this more. Maybe patients who've delivered at home and then bleed and continue to bleed. If you do retrieval medicine, you see a bit of this because they're the patients who continue to bleed and really become very, very unwell. And the fourth group are the patient who is pregnant and sustains trauma. So I'm going to talk about numbers 1, 3 and 4. So the PV bleeding patient, and the postpartum hemorrhage patient, and the pregnant trauma patient. So case 1 is really probably something that you see almost every day. I know that Dr. Vivek, who was on night shift last night, saw, I think he said 5 or 6 of these patients overnight, just last night. 2 of them went to theatre, and we'll talk about the conditions that those 2 had. So 2 of them went to theatre, 1 at 4 a.m. and 1 directly afterwards. So that was a busy O&G day, but I think all of you will have experience with this. So who can we ask? For now, what would be the things you think about if you saw this patient?
First of all, I'd like to find out whether she's pregnant.
Excellent. So how would you do that?
Just take a serum beta HCG.
Okay.
And abdo scan as well.
All right. So
together.
Before we jump to scanning, yeah. So what in history would you ask?
LNM.
Yep.
Danny.
Yep.
How many kids she had before.
Right. Excellent. So you're gonna have to wait a bit of time for your beta HCG. How long does it take to come back from in the taper?
About 45 to an hour sometimes.
That's quite quick, I reckon. Obviously, how about in Nandi, Cara?
No beta.
No beta HCG?
No beta HCG. We usually we ask them to buy the pregnancy test kit.
Yeah, and that's what we often we often do that here too in Zula. Yeah. Okay, good. So we want to know if she's pregnant. So as Finau said, that's probably the number one question, isn't it? And every time I do ward rounds here in Zula and I have a woman of childbearing age, regardless of what they've come in with, I always want to know if they're pregnant or not. And it can become a bit of an obsession, but I think it's a very healthy obsession. Because we all know that some of these patients, they don't present like textbook cases, they present in very unusual ways. I know Vandana's got a good story to share, and she likes to sit right at the back as far away from the microphone as possible, so I'm going to make her come and sit right at the front here near the microphone and share her story with us. The large ovarian. Yeah.
I had a 40 years old lady. She presented just with weakness of bilateral lower limbs, and the only other history she gave me was that she had done pregnancy test 2-3 months ago and it was positive. So on arrival she was very looking, cool and calming. So we the abdomen, she just had mild tenderness in the lower abdominal region. At that time, I didn't do the V speculum, so I just stimulated her, gave her bolus liter fluid, collected all the blood at that time. And then, because the suspicion was a bit strong of ectopic, I went ahead to do VE and speculum. Speculum didn't have any remarkable finding, but VE, she had CT positive, and she had the right adnexal tenderness. And luckily we had learned some scan skills, so I did the fast scan on her, and I could see the fetus there, the limbs movement there, heartbeat present. So it was like, is it ectopic or intrauterine? And then just beside that fetus, I could see another mass. So I was a bit confused whether it's uterus mass there and then adnexal ovarian, I mean some ectopic, or whether it is intrauterine. But given her clinical condition and examination findings, it was more towards ectopic. So I informed the ONG registrars as well that I have an ectopic case for them to review. They came in half an hour. Within that time I did another scan. She was starting to have positive fast scan. She had some fluid in the hepatorenal pouch. So it was getting more clear that it was more like an ectopic. The junior registrar wasn't sure that it was ectopic. He thought there's a placenta there, so it's more like an intrauterine pregnancy. So he called his senior registrar. Senior registrar, when he came in, by that time there was more fluid in the abdomen, and then he was saying, no, this is definitely ectopic. We need to take her to theta, but I think we should wait for the proper radiologist as well, or to scan. And then he discussed the case with the consultant, and the consultant said to take her to theta straight away without waiting for radiologist. But by the time radiologist had also come, and then she just confirmed our findings. So in the theta, it was ovarian ectopic. Baby was the big baby, about 15 centimeters, about 30 centimeter size baby. And it was slowly.
It's not supposed to happen. This is what I call the only in Fiji cases. The ones that aren't allowed, really physiologically impossible, but do still occur here. So it was, what, a 20-week, 15 week, with a placenta sitting on the ovary of fetus. So very, very, very unusual case. So thanks, Vandana. How about you, Arvind? Have you seen any ectopics in Nassori? Yeah, and have you had to run them down the road very fast?
Yeah.
Yep. How do you confirm pregnancy in Nassori?
We have ultrasound scan there as well.
Mm-hmm.
So we basically do the pregnancy test kit. We
Yeah.
leave it available with us all the time.
Okay.
And then if it's positive, we confirm whether it's extrauterine with the scan.
Okay. Do the patients have to buy the pregnancy test?
In the daytime they do. In the night we have.
Okay, you have some backup. Yeah, yeah. Okay. And how about Sigatoka? Amos, have you had any scary
I think the
ectopics?
story with Nassori is same as for Sigatoka.
Yeah,
We do have a backup of pregnancy kits in A&E
yeah,
in the DD cupboard.
yeah.
And if it is in the daytime, we basically tell the patient's relatives to get it from town, which is nearby. But if in the night or sometimes in the weekends when our X-ray, scan technician is not available, and our pregnancy kit is positive, we just refer across to Lotoka with a high suspicion of ectopic. But if ectopic is unstable, we call the flying squad to operate in Sigatoka.
Yeah, right, great. And would that be the same in Nandi? If the patient's really unstable, do Latoka come to you?
Yep.
Yep. Right, excellent, good. So as we've gone through, first of all, if they've got bleeding, you want to know if they're pregnant, and ideally you want to know what kind of dates or have a little bit of an idea. I think Vandana's case was extremely unusual. I've never ever heard of a 15-week ectopic with a placenta. I mean, it's just not supposed to happen, is it? They're supposed to die at 12 weeks or something. But this goes to show that we get taught a lot of things throughout our careers, and then there'll always be the one patient who proves every single rule you've ever learned wrong. And it's always in the middle of the night. I don't know what it is about pregnancy-related emergencies, but the 4 a.m. seems to be the key time, which is when we're at our most tired. So obviously the PV bleeding patient, most of them are very, very stable, but we always want to think about the worst case scenario because we're emergency physicians and we like the adrenaline pumping stuff. So we want to know, are they shocked or not? Because some of these patients will be very, very stable and some of them will be very unstable. So there's a big spectrum. If they do have an intrauterine pregnancy, we want to know whether that pregnancy is alive, but of course, more importantly, the parents obviously really want to know if that baby's alive. This is certainly something that it's very, very upsetting for people who are having PV bleeding when they know they're pregnant, because of course they're fearing that something bad has happened. As Fernell said, we want to take a bit of history. We want to know when their last menstrual period was, what their last pregnancies were like, how heavy is the bleeding, have they passed any products, and I think pain as well is really, really important. Do they have some sort of grumbling lower abdominal pain, or do they have some severe pain in the left iliac fossa or the right iliac fossa? Because I think that can be a bit of a clue before you get your pregnancy test result. If you're sending off a serum beta-HCG, you want to make that kind of risk assessment in your head about how likely is this to be an ectopic, and how likely is this going to be a patient that is going to become unstable and need to go to theatre. And obviously there's risk factors for ectopics, like there's risk factors for many conditions, but we quite commonly see patients who have no risk factors. So Vandana very well, I think, stated how she resuscitated the patient first, because who cares what the speculum shows if the patient's got no blood pressure, You really want to try and resuscitate patients first before you make any kind of attempt to examine them properly. And then when you do your PV, you want to know if the os is open or closed. And you can get a bit of an idea in some patients whether they've got pain on one side or the other, whether they're CET positive, but you can get those findings with other pathologies as well. Some of this stuff is based on transvaginal scanning, which obviously we don't really have access to here in Fiji. So transvaginal scanning, certainly in Australia where I'm used to working, would usually be the way to go in a very early pregnancy. So you can detect an intrauterine pregnancy usually at about 4 weeks, transvaginal, whereas it's 5 to 6 weeks in trans-abdominal scanning, depending on the patient, depending on the skill of the sonographer. So if you have quantitative serum HCG, which some people do and some people don't, then you can make a little bit of a risk assessment, particularly on the patient where there's no intrauterine pregnancy but you can't see a mass in the ovary or the tube. So really there's this sort of concept that has only really come into the literature fairly recently, and that's the PUL, the pregnancy of unknown location. And some of those turn out to be intrauterine and they're just very early, and some of them end up being ectopics. But usually, if the serum beta-HCG is low and less than 2,000, and the patient's stable and well, usually even if it's an ectopic, it's not yet going to cause any problem. But you always have to take every single case on its merit. And then, of course, if you're looking at an intrauterine pregnancy, so you don't really worry about the ectopic anymore, but you're wanting to know, is this patient still got a viable fetus or not? Then you're going to look at, do they have a heartbeat? Is the os closed or is it open? What size is the sac? You can get fooled by seeing a single sac, or what's called a pseudo-sac in the uterus on ultrasound. And unless it's got that double sort of ring kind of appearance, then it can just be a pseudo-sac, which can just be blood clot or something else. And people have been fooled before when they've scanned and seen this single sac and thought that's okay, it's intrauterine, but they've actually had an ectopic. So it is important that people who do these scans recognise that, and they're trained into dental, etc. So this is just a few sort of guides to whether the pregnancy is likely to be viable. Obviously this sort of stuff, I mean, although the parents always want to know, it concerns us a little bit less, because what we're really worried about is more the health of the mother and whether she needs to go to theatre. And obviously it's important to know whether the pregnancy is going to survive, but that's not really the main part of our job. We usually hand that over to their own GT. So the first patient, well, out of the two of Vivek's patients that went to theatre overnight, the first one was an ectopic and was unstable, and the second one had what sounded like cervical shock. So was miscarrying and had products of conception lodged at the os. And what tends to happen then is you get this intense vagal stimulus. So if you see a lady with PV bleeding who's bradycardic and hypotensive, think about this. It happens from time to time, and it's something that you should be able to do something about. You may want to try some atropine, but really the main thing is to have a look at the speculum, and if the products sort of lodged in the os, try and get them out with some forceps and gauze, that sort of thing. And usually then they start to get better. Occasionally they'll just continue to bleed at a very brisk rate, and they're the ones who need to again go urgently to theatre. So it's a less common cause of requiring urgent resuscitation and operating theatre, but it does happen from time to time. So you really need to be aware of it. Okay, moving on to the second case. So I'll let you read that for a minute. So this lady's actually out in the rural area, and she's just had a delivery at home. So I'm going to hand over to Shivani over here, and I'm going to ask her what she thinks about this case.
So this case is a 40-year-old female with 38 weeks of pregnancy, and she's multiparous. So elderly female, multiparity, still bleeding, heavy PV loss. I think of postpartum hemorrhage as my first diagnosis.
Okay, good. And what are her risk factors for postpartum hemorrhage? Given what you know from that.
Age. Priority.
I don't like the way I've just been called elderly, by the way.
Middle age. Middle age.
Or middle age.
Young.
As Joe said, she's a multip, so she's had lots of pregnancies before, so that's a risk factor for getting uterine atony after delivery.
That's the precipitous delivery.
And the precipitous delivery. So what does precipitous delivery often cause? Why does that make you bleed? Tears, yeah, excellent. So you're more at risk of tears. So I like to think of the 4 T's. It's a bit like reversible causes of cardiac arrest, isn't it? But tone tissue, trauma and thrombin. I think you guys in TG are much better at this kind of stuff, because you've all worked in the peripheries where you've been the single medical officer, and I'm sure you've all dealt with this sort of stuff much more than us from other countries. But always good for a refresher. The 4 T's, think about risk factors. Think about, has there been any trauma? Was the placenta delivered? Has it been delivered in completion, or is there still some placenta in there? And obviously a history of clotting disorders is useful. However, strange things can manifest in strange ways. I was hearing about this case recently out in country Australia about a bit of a hippie lady who liked to take lots of alternative medicine, and she'd been taking a lot of sort of alternative medicine for her joint pains, and she had an enormous postpartum hemorrhage, and it ended up that this medication she was, over-the-counter medication she was taking, had made her coagulopathic. So yeah, every now and again you see these strange, weird and wonderful reasons. So risk factors, 2/3 of people with big PPHs have no risk factors. So again, like everything, we learn about all these risk factors, but often the patients we see have no risk factors. However, prolonged labour, precipitate labour, so too long or too short, obviously dysfunctional labour where the baby's the wrong way round or was never going to come out for whatever reason, multiple pregnancies, that makes sense, or too much fluid, and pre-existing abnormalities like fibroids. Drugs that we sometimes give for other reasons, such as magnesium if they were preeclamptic, general anaesthetics and tocolytics, and then of course trauma and retained placenta. Coagulopathy usually can be predicted. Usually it's because they're already on some drugs or they've had one of these very nasty conditions like preeclampsia, HELLP syndrome. But abruption is another thing we need to consider, and fetal death in utero. So how do we manage them? Pretty much like everything we do in emergency medicine is ABC, isn't it? Usually these are fit. Even the 40-year-olds are young women. And so they actually cope with a fair amount of blood loss, and they don't tend to get compromised until they've really lost a couple of litres at least. And that's thank God for that. I guess that's the way we're designed. Otherwise, even more women would die in childbirth. But so they'll lose a lot of blood and they'll still be resuscitatable. And we really, the focus is C. Obviously, usually A and B are okay, unless they've got other pre-existing conditions like cardiac conditions. And like most things we do, it should be simple. Think about direct pressure and how you're going to compress the uterus. So you can try rubbing the uterus to try and make it contract. If that doesn't work, then there's bimanual compression, which is obviously very uncomfortable for the lady, but if she's bleeding to death, then that's what you need to do. If you still can't stop it, then a fist over the aorta is a temporizing measure. Obviously that means you have to stand there, and getting someone to make sure that the whole placenta has been delivered and taking the clots out of the vagina. There's drugs you can give. Now I'll ask you guys which ones of these are available. I presume you have oxytocin?
Yes.
How about ergometrin?
Yeah.
Yep.
Yeah.
Misoprostol?
Yeah.
Yep. And prostaglandin F2 alpha?
Yeah.
Yep.
Yeah.
Okay, good. So that's great. The
Only
prostaglandin
in labor ward
only in labour ward,
Only
and probably not in every
for
hospital.
induction of labor.
Yeah. Okay. So it's good. It's good to know where these drugs are. Some of them obviously have to be kept from the fridge. It's good to be able to access them when you need them. And often we're very unfamiliar with the dosages and the dilutions and that sort of thing. So I think with any drug that you don't use regularly, it's really important to have some kind of guideline or reference, or bring someone down who uses it a lot, because we're all going to be very stressed in this scenario. Sometimes they need to go to theatre. Sometimes they need to have a urinary catheter with a big balloon, or what's called a Bakri balloon, which is specially designed for this. Sometimes they need to be packed, etc. And obviously, if nothing works, then they end up having hysterectomy, sadly. Monitoring. So obviously, all of these unwell patients need close monitoring, hemodynamics and temperature. Let's make sure they don't get too cold because they've lost a lot of blood. We've usually given them cold or cooler blood products back. Trying to monitor their coagulation if we can. It's a bit of a challenge, particularly at the moment when I don't think we've got any coag tubes left or something at the moment. I was hearing earlier, but we've got some now.
Finally.
Oh, we finally got some. That's good. Fibrinogen, I don't think we can measure here, can we? No. Okay. Renal function, really, really important because they're very at risk of renal injury. And also monitor for other organ injuries like lung injury. Check on their fundal height, make sure the uterus is shrinking down where it should do. And unfortunately, once they stop bleeding, they start clotting. So this is just such an awful thing about two very high risk for bleeding to death conditions. One, PPH, and the other one's pelvic fractures. So once they stop bleeding to death, they start clotting and dying from clots. So once they stop bleeding, we've got to think about actually giving them prophylaxis for DVT-PE. Moving on, so 30-year-old female, 30 weeks pregnant, front seat passenger in a car accident. It's raining again here in Suva. I thought it was going to be another one of those days where everyone was crashing their car, but luckily it stopped. That was good. So this patient goes 50 k's into a tree, but she got up. She got up and out of the car herself, but she started complaining of abdominal pain. Who should we ask? I reckon the Nandi crew. What do you think could have happened? What are the possibilities here? Nandi, Team Nandi. Satvir.
She could be bleeding in her uterus, like a retroplacental clot or something like that.
Yeah.
Or it could be just normal from the trauma, like bone or something. We have to assess first,
Yep.
do a CTG and see that the baby is okay, like looking at the fetal heart and assessing also that the baby, like the uterus is not contracting, it's not the contractions of the uterus causing the abdominal pain.
Good, excellent. So
And
could be
also-
contractions. Yep.
And also you have to assess other things. It could not only be the baby, but could be other things as well, spleen or liver or other things.
Excellent, good. So why is trauma in pregnancy a little bit tricky?
Because you got the baby there.
Yep, so you've got two patients, that's one reason. Any other reasons?
One goes wrong, the other could also go wrong.
Yeah, true. So the principles are, as they always are, look after mother and that will look after baby. So treat the mother well and the baby, ideally will do well as well. Good. How about assessment? So how about things like vital signs in the pregnant patient?
The physiology is a bit different.
Yeah, good. Team Latoka, what do you reckon?
They won't get a tachycardia unless there is a profound hypovolemia.
Yep, good.
So, because they have increased blood volume because of pregnancy.
Excellent. So you can mask a lot of blood loss in terms of vital signs. They'll be very normal until they've lost maybe even 2 litres. Yeah. Wearing a seatbelt? Yeah, okay, why is that important? Sorry, what was that? Repeat?
He's saying the black belt may cause some trauma.
Okay, so direct trauma from the lap belt. Yeah, good.
Yeah. But in terms of the physiology, so they've got an increased blood volume. They're going to take a longer time to reveal the fact that they've got exsanguinating hemorrhage. But I think they've got some pulmonary changes as well, haven't they?
Yeah,
So
what about breathing? What happens to breathing in pregnancy? Amir?
Since the uterus is growing in the abdomen, it pushes the diaphragm up a little bit, so the total tidal volume that the patient is trying to maintain increases. They try to get their respiratory rate up to get the same oxygenation. The other thing to think about is the organ viscerus, because it's just anatomy. Because the uterus is growing up, and 30 weeks should be significant enough to push the liver, the spleen, and the kidney is not much of a kidney, but liver and the other foregut structures a bit higher.
Yep.
So sudden compression abdominal traumas can eviscerate structures through the diaphragm. So diaphragm evisceration would be something we should worry about.
Okay, so good. So they're going to normally have an increased respiratory rate. They also have a decreased functional residual capacity. It's good to think about always giving these patients oxygen. We're sort of moving away from always giving patients oxygen, which I think is a good thing, but probably the pregnant trauma patient is someone we should think about giving oxygen because they have decreased reserve. They're going to be tachypneic anyway, so it's going to be hard to assess. Again, their normal vital signs are abnormal, if you like. And some of their organs may get pushed up. So what if this patient needed a chest drain?
Yeah.
Yeah, so you want to go a couple of spaces higher because you don't want to be sticking it into the spleen or the liver, do you? Okay, and in terms of management when this patient arrives onto your bed, is there anything particular you want to think about because she's pregnant?
Positioning.
Positioning, what about positioning?
Lie them supine, you might cause problems for them. You can put them in the left lateral position.
Yep, excellent. So they want a left lateral tilt of some sort. Now, it's really good to think about this before you get the patient and what you'll use. So you need some kind of wedge. Often it's something that some X-ray departments have. They have lots of sort of funny wedges to prop people in different positions for their X-rays, but it's kind of good for. It'll probably be good for us to think about whether we can make some kind of wedge so that we're prepared for this if it comes in. We know where it is. So some sort of foam wedge or something that just tilts them a bit on their left, because obviously they may have spinal problems. You want to make sure you maintain that spinal alignment, but you really want to think about this early, because a bit like cervical collars, if you don't think about it when they come in, you kind of forget about it. And so if you don't tilt them straight away, you kind of forget about it, and then a bit down the track you realise, oh, hang on a minute, they're hypotensive, and that's usually because they've got IVC compression from the uterus. So it's really, really important, obviously, in the third trimester. Good, excellent. What about their blood results? Any change there? Anything change in pregnancy?
Platelets get low, HB drops.
Yeah, why does the HB drop?
Hemodilution.
Dilution.
Yeah, good. Okay, so they increase their red cells, but they increase their plasma volume more, so that's their dilutional factor. So the normal hemoglobin would be less. Yep, good. We mentioned
hematocrit.
what was that?
Decrease the hematocrit.
Decreased hematocrit. Yep. We mentioned the increased respiratory rate. So if we did a blood gas, what would we expect?
CO2 to be higher than normal.
Carbon dioxide.
Sorry, lower.
Yeah,
Lower than normal.
Lower.
Good. So they have a respiratory alkalosis, which is usually partly compensated, but so again, your normal blood gas will be different. Okay, good. Now, obviously, pregnant trauma patients, they can get the same injuries that non-pregnant people can get, and then they can get a few injuries that are unique to pregnancy. So, Satvir mentioned a retroplacental clot, otherwise known as placental abruption. So, think about abruption in this sort of patient, and they don't need much in the way of trauma. They can do this just by slipping and falling. And so someone like this is very high risk for an abruption if they've got abdominal pain. So how would we diagnose an abruption? Okay, someone said scan. Is that Natasha? So Natasha, how accurate is scan at diagnosing abruption in this scenario?
I'm not very sure.
Okay, Vandana's shaking her head. I'm going to ask her.
It's a clinical diagnosis rather than a scan diagnosis.
So clinically, how do you diagnose it?
And the abdomen will be hard or rigid, tender all over. And the CT will be showing poor fetal variability.
Okay, so there's definitely clinical features. How about bleeding? PV bleeding or no PV bleeding? May or may not, good. Okay, so they may or may not have. So it's often concealed, yeah, good. So absence of PV bleeding certainly doesn't exclude it. In fact, they often don't have PV bleeding, but they usually have some tenderness. And the ones I've seen are the ones that went catastrophic, the less where the patient is still stable, they just seem to have a hell of a lot of pain that's very hard to control. And they may otherwise look fine, and they may not even be that tender, but they just seem to have this pain that's very difficult to treat. So PV loss may or may not be present. Vandana very correctly said that it's mainly a clinical diagnosis. In fact, scans are about 50% sensitive, so you're going to miss half of them. So, okay, abruption, good. What else can happen in terms of pregnancy-related injuries? I can hear murmurings.
Yes. Clara said premature labour.
Excellent, Clara. How are we going to know if she's having premature labour? Okay, so you can put a CTG, but what about the clinical features? So contractions?
Couple long-lasting contractions.
Okay, excellent. Yeah. How about how do we normally diagnose labour in a non-trauma patient?
Contraction gonna be.
Yeah, obviously. So we're looking for dilatation and effacement of the cervix, aren't we? But we want to be very careful about doing VEs and speculums in trauma patients, and we want to make sure that it's only done by the right person once and in a nice sterile environment. Because we don't want to be introducing infection at this stage, do we? Alright, good. So she may go into labour. We may diagnose that by regular contractions. We will put on the CTG, and what will we look for on the CTG? Contractions. Yeah. So fetal distress, so bradycardias, tachycardias, late decelerations, all that sort of stuff. Good. Okay, so how about asking the patient if the baby's moving? Could we do that?
Yes.
Yeah. So don't forget that. It's it's a reassuring sign if they feel the baby's moving normally. Often you'll get the actual very worried mother saying, I haven't felt the baby move, I haven't felt the baby move. So that usually prompts you to think about that, but it's definitely good to ask that sort of stuff. Alright, so abruption, we've done premature labour, anything else? Any other injuries? Pregnancy related? Uterine rupture. Amit, tell us about uterine rupture. How are we going to diagnose that?
So uterine rupture, it's going to be hard to diagnose it because all the clinical signs that a uterine rupture will elicit will be present in the placenta. So, but one thing to watch for here will be free fluid in the abdomen of this kid. The other thing would be there would be point tenderness. The place of rupture will be more tender compared to the other part of the abdomen unless the blood goes in, the other parts will become more tender. There may or may not be PV losses or may not have any LICA discharge, amniotic fluid discharge. Fetal stress may be present and mother may be hemodynamically unstable because they are bleeding intraperitoneal.
Great, so usually uterine rupture is quite catastrophic and mother and baby are both quite unwell, but I guess like all things, you can have a total rupture or you can have a rupture of part of the uterus, so it can be a little bit more subtle. Certainly I've only seen one and it was pretty devastating. But remember, in the trauma patient, who knows, it could be the uterine rupture, it could be all sorts of other things bleeding into the abdomen. Until you've got enough investigations, it's hard to know. But pretty devastating. You might be able to palpate sort of fetal parts, that sort of thing. Good, excellent. So I think we've gone through most of these things. There's 2 patients. There's specific complications to pregnancy, and there's the usual things you can get with any trauma patient. There's anatomical and physiological changes. There's changes in the vital signs and with the biochemistry. There's also a lot of anxiety around pregnant trauma, understandably. So the mother's going to be distressed, the partners, if they're there, going to be distressed, and the staff are usually going to be a bit more distressed than normal. Thinking about radiation and drugs, obviously, there's going to be concerns around that, particularly if the patient isn't that unwell. You're really going to think about what is actually risk-benefit in terms of radiation versus, clinical monitoring. And obviously, if they need an investigation, they need an investigation. So that's also important to know. When I was working at a trauma centre in Melbourne, it was quite ironic because we got a patient transferred from one of the outlying, outer metropolitan hospitals that actually had obs and gynae services to our trauma centre that did not have obs and gynae services, basically because they couldn't work out whether it was justified or not to do a CT scan. It was just the most ridiculous sort of transfer when the patient could have stayed there and been investigated, but they kind of wanted to pass the buck, if you like. And this patient actually ended up having an abruption, so we had this woman 20 weeks with an abruption and absolutely nothing else wrong with her. So she had no other traumatic injury identified, and she had a purely obstetric complication, and she was in a non-obstetric hospital. So yeah, there's a lot of irony in that. Obviously, if you're lucky enough to have an MRI scanner, that's probably the way to go if you can, and the patient's stable enough because it's not ionising radiation, but we probably don't really know what MRI does to fetuses yet. And remember that it's actually in the first 8 weeks that the fetus is most at risk from radiation and stuff. And usually, these aren't the patients we're talking about patients in 3rd trimester. So if they need scanning, they need scanning. Think about whether the fetus is viable, because if it's less than 22 weeks, then regardless of whether they've had an abruption, you're not going to be doing an urgent C-section because the baby's not viable. So that is kind of important. If you can get some firm dates, if they've had a scan before this has happened. The other thing is perimortem C-sections. Anyone know what I mean by a perimortem C-section?
Delivering the baby in C-section once the mother has passed away.
Okay, good, Romy. Can you tell us why that might be done?
Because if the mother has stopped the circulation, she's going to cardiac arrest. You need to deliver the baby as soon as possible to prevent compromise of the baby.
Yeah.
Viable.
That's definitely part of the reason, and in fact, the other reason is that delivering the baby may allow you to actually recover the mother. I mean, it's not common. It doesn't commonly happen, but if you think about this baby that's providing aorto cable compression to the mother, then your CPR may not be effective because of that. And the theory is, if you get the baby out, you might have a chance to save the mother. So you may save the mother might die, and you might save the baby. Any idea about how quickly it has to be done?
It's within 10 minutes, isn't it?
Yeah, it's actually probably more like 3 minutes.
Yeah.
3 minutes, and so most people don't do it till it's too late, because it's kind of one of those concepts that most of us feel quite uncomfortable with, unless you've kind of used to working in war zones, or unless you've done a few before. It's not something that I think we're likely to do at the 3 minute mark. We're probably going to carry on doing CPR, and then we're probably going to do it too late if we do it at all. So it's actually quite uncommonly done. There are descriptions of it being done, quite successfully. But it's something that's really quite hard to get your head around doing it in 3 minutes, I think. And the other thing I mentioned before is disposition. So often trauma centres, I don't think you have this problem in Fiji, but certainly in some more developed systems you have this problem where the major trauma centres don't have easy access to obstetrics and gynecology services often. So they have to have agreements with another hospital or with the nearby women's hospital or whatever to have a way of co-managing these patients. We talked about some specific complications of trauma patients, so aortic cable compression, don't forget to tilt them. Feto-maternal hemorrhage we didn't talk about, so what's feto-maternal hemorrhage? And what's the issue there?
Missing of blood, RH.
Yep.
Isoimmunization.
Excellent. So isoimmunization. Do you guys have anti-D here in Fiji? Yeah. Yep. Okay. Good. So something to think about if you need to get the blood group of the mother, or you need to ask them and find out whether they're negative or positive. Abruption we talked about. Always remember abruption, because abruption is common, can be hard to diagnose. You'll miss it half the time if you just rely on scans. I've noticed a bit of a tendency, certainly here in Suva, to do ABC ultrasound scan without actually thinking about why you're scanning and what you're looking for. So I'd strongly urge you to think about whether what you're looking for will actually show up on the scan anyway. More important to think about clinically what their risk is before you send them for a scan, particularly if you're sending them out of the department for a scan. Uterine rupture, usually quite dramatic, but obviously the sort of patient who gets uterine rupture may also have a lot of other injuries, particularly pelvic fractures. So it can be a bit difficult to know, is this patient actually having major hemorrhage from pelvic fracture, or is this uterine rupture? You know, have they got a liver injury, splenic injury, that sort of thing. Premature rupture of membranes we didn't really talk about, but I guess that's the same as the non-trauma patient in terms of how you manage that. Beware of introducing infection, that sort of thing. Premature labour, as Clara said. Fetal trauma is very rare, thankfully, because they're cushioned by that nice bag of fluid around them and the uterus and the mother. But you can rarely get head injury to the fetus if there's a really nasty pelvic fracture. Amniotic fluid embolism, rare but important to think about. And DIC, something that pregnant women definitely seem to get a lot of. When it goes bad, it goes really bad. Regardless of the cause, if a pregnant patient is really unwell, think about DIC. Specific tests, you obviously want to know the blood group and you want to think about giving anti-D. Do you do Kleihauer tests? The Kleihauer test tries to estimate how much mixing there's been in terms of feto-maternal circulation. Where I'm from, the O&G registrars love them, but it doesn't seem to change management at any point, and they always take too long to come back. So if you're going to give anti-D anyway, I think the idea is that you might need to give more anti-D, so it might guide subsequent doses. It's probably why the ED people don't care about it and the O&G people do. That's usually the reason. It's the patient's out of our department by the time it's relevant. Ultrasound, obviously, fast scan can help. If you see a fetus, can get a heart rate. And you know, if you're a good scanner, you might be able to look at the placenta well, but this takes a hell of a lot of skill. To look at placental position, to look at whether it's intact. And these patients, you know, they're not these lovely ambulant pregnant patients that you can move around. They usually lay flat on the bed in the seat follower, etc. So it can be really hard to get a decent scan in terms of a pregnancy type scan. So 50% of abruptions will be seen on scan, and in 50% of cases with these abruptions the baby will die. So we shouldn't be saying this because Vandana's about to give birth, probably during the exam. I think I decided she's timed it to go into labour during the OSCE exam, just to give us a little bit more excitement. So we've got to all watch out for that. And I reckon we might just incorporate it into the exam if it does occur. We'll see how we all react. Yeah. Anyway, well, I hope it doesn't happen. So CTG monitoring is really, really important and is very, very sensitive. So if you detect an abnormality in the CTG of the fetus or the baby, think about what's going on with the mother, because something's happening with the mother that you haven't picked up. So you may have not picked up that the mother's bleeding, but they are if there's something wrong with the CTG. So you can actually use it, you're monitoring the baby, but you're actually monitoring the mother via the baby, because if the fetus is in distress, it usually means there's something going on with mother. And so if we could check fibrinogen, then it would be high normally in pregnancy. So we don't check it, so we don't care. So just going back to the normal anatomical and physiological changes and how they may make things difficult for us. So you've got an increased risk of failed intubation times 8 when people are third trimester pregnant. They have large breasts, so it's nice to have a laryngoscope with a short handle, which is called a Kessel blade. But usually in ED we don't have these luxuries, but it can make it really, really quite difficult, and you might need to, again, try and position the patient, which may conflict with your spinal management, but obviously airway is the most important thing if you've got to get a tube down. They're definitely at increased aspiration risk, and their FRC is decreased by 20%. So they're going to desaturate much earlier if you're going to intubate them. So really think about really good pre-oxygenation. Think about running nasal prongs while you're intubating them so they get that passive flow of oxygen. And for most of us that means getting an extra oxygen cylinder to the bedside because we don't have the luxury of 2 oxygen outlets. But I think in these sort of patients it's really worth doing, just like any patient who's going to desaturate early. So the same with a child, the same with a patient who's already hypoxic. Think about running high flow nasal prongs while you're intubating. Think that it's going to be difficult, so prepare for difficulty and get all your difficult airway equipment by the bedside. Even if that just means asking Shivani to produce her bougie from her pocket, which is usually what we do here in SIVA. I think we need to source some more bougies for everyone on that note. Ask Father Christmas again to open his checkbook. Breathing, give oxygen for everyone. Remember that they've got decreased reserve. And maternal hypoxia equals fetal hypoxia equals poor outcome. And the diaphragm's about 4 centimetres higher at term, so put your chest drain higher. It's always better to put it a bit higher than a bit lower. Remember how high the spleen and the liver can really be in a trauma patient. Circulation, we didn't mention this, but depending where you are in pregnancy, you may normally run on a lowish blood pressure. It can be very difficult to know if you've got a patient with a blood pressure of 90, if they're around 20, 26, 28, 30 weeks. Is that normal for them, or is that low? Because they're going to be relatively tachycardic and hypotensive to start with, but they've got a 30% increase in their cardiac output. So they can lose 30% of their blood volume before they become more hypotensive. If you do damage your uterus, then you can get massive blood loss, particularly as you come to term. I guess that's another reason why uterine injury, like a uterine rupture, can cause such profound shock. And remember the aorto cable compression, which can decrease your cardiac output by 25%. Nasogastric important because they're not emptying their gut as well because of the progesterone, so they get gastric stasis, they get bowel stasis. Their peritoneums, they're sensitive, so I mean this occurs to anything happening in a pregnant patient. You know, it can be difficult to diagnose appendicitis, they don't have such good peritoneal signs, but the same with when they've got bleeding into the abdomen. And the intestines are going to be a bit higher, but usually they're a bit protected by the uterus, so that's good. And the spleen and the liver are going to be vaguely in the same place, so a little bit higher maybe if they're being pushed up, if the baby's near term. And the blood is more likely to be injured. So you'll pretty much know all this already. We're going to look for fetal distress, and we're going to look for contractions. So if there's any contractions, you want to keep the patient in for at least 24 hours if the fetus is at an age where it's viable. And if they're having more than 8 contractions an hour for at least 4 hours, then it suggests they've probably got some degree of abruption. Management is like all patients, so we're first of all going to seek and treat major life threats. So we're going to take that A, B, C, D, E approach. We're going to do a primary survey and a secondary survey. But just remember the extra things. Remember to tilt them. Remember that we're probably going to apply oxygen early. And we really need to do the usual preventing hypotension and hypothermia, which is less common here, but take anything wet off them. And try and maintain that uteroplacental blood flow, which is going to be good for the baby. Always remember analgesia. Think about local blocks. Obviously, depending what age the baby is, we want to think about the impact of the drugs we give on the baby, and obviously controlling bleeding, splinting fractures as we do in any trauma patient. So do the basics well. Think carefully about positioning and think about early oxygen. You're going to have a special look at the uterus as well as the abdomen as you do in any trauma patient. So think about, do they have tenderness over the uterus? Does it feel hard, suggesting abruption? But it may feel normal and they may still have an abruption. Can you feel the fetus? Is it head down, or can you feel what presentation it has? And have a look. So make sure you've actually had a look for blood or fluid, because the trauma patient may not be able to tell you. Like flying flat on their back with a C-collar. So have a look. Make sure you have a look and you document that. If you're going to do a speculum exam, which may be really important, get it done by the most experienced obstetric person that you can. Try and do it in a very clean, sterile way, because they may have some rupture of membranes, and they may decide to, if there's no other problems, they may want to try and get them to term anyway. So make sure that you don't introduce any infection. In terms of deciding what should go on with fast scan, obviously fast negative and fast positive scans will change your decision making. However, really, as it always is, it's how unstable the patient is. So if they're not unstable, then you've got a bit more time to think, consult, but if they're unstable, then they need to have an urgent laparotomy. The ones with fast negative, it doesn't mean that everything's okay. It doesn't mean that the baby's not in distress, so they still need monitoring. Certainly the guideline we used to run on was if they seem to only have minor injuries, they've got a negative fast scan, the initial CTG looks healthy, and we usually give them 4 hours, minimum 4 hours of CTG monitoring. And then if they're allowed home, we make sure we give them firm instructions about returning if they're bleeding pain or premature labour. If they have injuries that need them to stay in anyway, we leave the CTG monitoring on, and we make sure that that's regularly reviewed by an obstetrician. So, I guess it depends on your index of suspicion and how the patient is. So perimortem C-sections, you really want to get the baby out within 5 minutes to really have any chance of helping the mother and the baby. There are some good, I'll see if I can find, there's a good case report of this done quite recently by a retrieval doctor actually, which was quite impressive. But have you had any experience, Rohit, with
perimortems?
Yeah.
Yeah, we've done a couple of them.
Yeah.
I only had one survive. The baby was forked. So yeah, usually we say the cut doesn't have to be pretty, just get the baby out, right?
Yeah.
And if you can do a horizontal uterine incision after the straight down vertical external incision. But that's definitely right. Keep CPR going. Have somebody do CPR while you're cutting. Don't stop it. That's something. Usually in our trauma rooms we have a NICU, a small little neonatal unit, a little neonatal warmer in there. So that's something to think about in building a trauma unit, because that can be sometimes necessary. But again, the lethal triad is really important to think about. And with kids, the first thing you got to think about, you got to keep them warm, you got to keep them sweet, and you got to keep them dry. So those things. That's about all I can think about.
Yeah.
It's kind of straightforward. It is a heroic procedure, but that's why we do what we do.
Yeah. I think it's always good to talk to our US colleagues about this sort of stuff, because they seem to be have a lot more experience of opening chests and abdomens and any other body cavity in the ER. So it's good if you're set up to do it and you're trained and you've got the equipment and the personnel. I think it's a little bit more daunting for the rest of us that practice in less sort of set up places, but really the principles are the same. We talked about abruption, expanding fundal height. All of these things you may or may not see. I think it's quite a difficult diagnosis to make, and you may have any of these things or none of these things. So pretty common in major trauma. Think about 50%. So 50% picked up by ultrasound, happens in 50% of major trauma. So they're the patients who have multiple injuries and are going to be admitted to ICU for other reasons. And think about it in the patient who's just got pain that needs opiates and you can't find anything else wrong. Uterine rupture, we forgot to mention shoulder tip pain. I think that's a really important sign in any patient who has shoulder tip pain. You've always got to think about something quite serious going on. Yeah, pelvic fractures plus pregnancy, think about uterine rupture. So the most common thing you'll get with trauma is uterine contractions. Now most of these will settle, so you get a lot of prostaglandins released if you're pregnant and you get some trauma. Doesn't mean that you're going to go and progress to early labour. So again, they need to have regular contractions. They need to monitor how regularly they are. So obviously when you've got the CTG monitoring on, that's quite easy. If the patient is having other complications,